With equal control, still the diabetic group with PCI contributes with high lesion complexity scores. Now, you can see that on the few graphs under the treatment group, you can obviously see that MACE is much higher in this class of patients here, whether it be bypass surgery or PCI, but obviously worse with PCI. And with the diabetes group on the far left, you can see that there is a significant difference in the MACE result. Can be the preferred therapy. But if you're looking very carefully at all the others, where there's lesion complexity scores of more than 22, then you're talking about surgery being more preferred. You can argue that, well, this is a Texas scan, what about the other liner scans, maybe it better, etc., etc. But it's pretty obvious that, this is a point that we can discuss later. And I think Dr. Park will be discussing something close to this about next generation scans, and he might be touching on this. Now, I just had privilege of them to give me also a very short summary of the latest release of the 4-year follow-up of the Syntax trial. And here you can see that the follow-up has been well over 90% in both groups. And here again you can see that in terms of revascularization and MACE, it's going to be higher in the PCI treated group than the surgical group. And really you can see the way the two graphs are actually separating from very early on after the first year and all the way up to the 4th year. And again you can see that if you score them by the low, intermediate and high complexity lesion type groups, you can again see the difference in how significant differences in revascularization, mortality and MIs in the intermediate and the high risk group. So basically in summary, just from the 4-year results from the Syntax trial, you know that the MACE rates in the overall randomized cohorts were significantly higher for the PCI units and how they can manage lesions and get better treatment, we do not know. Is there any other medical therapy, post-intervention that can use that can actually modulate and make things better? We do not yet know or do not yet have, but eventually I think all this may come about. And with this, I just want to thank you all for your attention.
He is very close to us for Bangladeshi cardiac surgeons. In the early 90s, up to 2011, he tried his level best to develop cardiac surgery.
Thank you very much, my respected Chairman, Mr. Patron, dear members and guests. Good morning. And I'd like to first thank the organizers for gathering such a great number of experts from all over the world, and also giving me the opportunity to invited me. Unfortunately, my invitation was kind of late, so my slides are not going to be as good as the one that was just presented to you. You may see some of the same information, but because I'm a surgeon, I may give you a little bit of a different perspective. Again, as he said in his last slide, that the hard hitting goes on. But again, we have a job to do to our patients. So my starting comment would be that when the intervention to treat coronary disease was started, we found that it did make a tremendous amount of difference in the lives of our patients and also their mortality. So one thing we know for sure, that when we intervene to make things better, there is a unpublished study from Duke University where they have done all the calculations for several years, 2000 to 2008, and they found about 10,000 cases of diagnostic CAS, of which 23% had very significant coronary disease. And then they took those patients, it's a database basically, those who were treated, medical treatment, all the different levels were between 60 1% in 5 years, goes down to 22% in 15 years. And when we added, or they added PCI or CABG to those patients, and the results were dramatically different. That is 76% 5 year to 34% 15 year. So, as you see, we do make a difference, cardiologists and the cardiac surgeons. And if we just take the preservation of life and also the quality of life as an indicator, then this is something good for our patients. So, there were some studies and there were some debates going on for last 2 or 3 decades about what is the best treatment for our patients. And American College of Cardiology Foundation has done lots of work on it. And I'll present some of those in future slides. But basically for us to know that preventive coronary disease, coronary bypass graft surgery still is the gold standard, and PCI is, as was shown in some of the slides, even though we did not read between the lines, not quite certain. I mean, there are some studies going on in some centers, there are some, very aggressive cardiologists are doing PCI, the results I have made. But in general, as evidence, this is still not certain. Left-hand coronary disease, hands down, the American College of Cardiology says that it is inappropriate for PCI and appropriate for coronary bypass surgery. Despite all these findings and recommendations, our practices are heavily influenced for them. This syntax trial that was so nicely described by the previous speaker also can be looked at in a much simpler way, and I'll show you what we get out of it. Syntax trial, remember, it's a name after the synergy of PCI that is done by Texas and cardiac surgery. It was sponsored by industry, it was designed by cardiologists, and even though the cardiac surgeons sat on the panel, and they tried to find out what is that PCI cannot do that surgeons can do for previous disease and left-hand coronary disease. And what they try to look at the MACE point, which is major adverse CV events, which includes myocardial infarction, stroke, death, and they looked at all this tabulated. They wanted to show that PCI, the whole idea was to show the world that the PCI is not worse than cardiovascular surgery, coronary bypass. Mind you, coronary bypass surgery is still the gold standard. So it's a randomized prospective control trial. They screened 4,337 patients in 85 sites all over the world, and found that they screened them, found that 3,000 of them comes into the category of, you really don't find the kind of cases that should be really suitable for PCI. You can think about that. But anyway, I'm not talking about graft surgery or by PCI randomized. Most importantly, they quickly found out that after they started looking at it, of 1.4, which is very significant, as this has actually exceeded the pre-specified goal. And CABG patients, on the other hand, even though have better results, we all know because of the peri-procedural, those patients did not get their antiplatelet medications or statin medications immediately post-surgery. So there we have the 1-year mortality of PCI at 1.26, which is non-significant. Remember, this is non-significant. It doesn't mean that it is equal. colleagues held on to that and make sure that we know this is not significant. Next, there are other randomized studies done following the syntax pattern. 5 different studies, multi-centers, and they all came to the conclusion that CABG is definitely a more durable surgery, and also you don't need as much retesting and as much intervention. In this country, we call stenting put a ring on. When this ring is put on, the cardiologist can manage the patient. In other words, they keep on doing more and more studies on this patient and more stents get put on. So it's a lot of romantic relationship that exists because of that. They also showed that the CABG is equal or superior to PCI in the mortality outcome. Short-term advantage of PCI mortality is mostly very procedural, as I said, and when important thing to understand, I'm going to repeat what my previous speaker has said, when Lima was used for LAD bypass, the coronary artery surgery definitely had an advantage. When they took the syntax patients, the longer term follow-up, the curve diverges. In other words, it definitely shows more survival, and 13 experts, of which 4 of them cardiologists and 4 of them cardiac surgeons, and they have writers who wrote vignettes to illustrate different situations that exist among the coronary disease patients. And the experts then sat down and scored with appropriateness to inappropriateness from 1 to 10, scored all of these situations. And all the results were discussed, voted upon, and then was published. And this is basically what we say. The PCI is appropriate for 2-vessel coronary disease with or without diabetes, with or without heavy function dysfunction. But it is uncertain for those with diabetes, and it is uncertain for 3-vessel disease with diabetes, with or without poor heavy function, with or without. PCI definitely has been inappropriate for patients with aspirated left main coronary disease and left main coronary disease with added other diseases, diffuse disease, for example. And lastly, we should also know that they have decided that coronary artery surgery is appropriate for 2-vessel, 3-vessel left main disease with or without heavy function, dysfunction, and with or without diabetes. And also, we should point out, and that as was mentioned in the last session, that in acute situations, PCI has made a great improvement in our care of patients. We certainly believe, and also agree with our previous presenters, that in acute situation, to revascularize the ischemic area by either a bare metal stent, PCI, or a stent, regular stent. But if there is multi-vessel disease, what they do in our center, they will put a bare metal stent and let us go ahead and we have to establish the flow and let us go ahead and operate on them at a later date when we let you do. And another thing to understand is that as soon as the threshold of 3-vessel coronary disease is reached, the American College of Cardiology is telling us, wait a minute, that's not proper to do a PCR with patients. Because evidence suggests that those take cardiac surgery for the long run. Other thing, as was pointed out, the coronary anatomy is a big factor. Not all patients have a proximal LAD disease, proximal disease in the circumflex, or proximal disease in the right coronary artery. They have diffuse disease, especially diabetic patients have diffuse disease. The renal failure patients, which we operate on a lot of them in our center, have got multiple calcified lesions, and those really don't do very well with PCR, unfortunately. We need to argue about it because we believe, And there are also many cardiologists who feel that they can pretty much accomplish anything, but they do it at the cost of patients' life sometimes, patients' comfort sometimes. So a multidisciplinary approach where the more different atmosphere that when the patient is on the table, the catheter in the thing and given sedation, and the patient and the family is told, well, because we can put a ring on it and you'll be alright, why do you want to have a big scar in your chest? That's a decision how it is made most of the time, unfortunately, and I know that. Okay? So we should take a step backwards, get a multidisciplinary approach to all of these, and select a treatment that is really appropriate for the patient by taking care of the least risk and most benefit. And this is what is supported by evidence, not what we wish to see happen. Remember, the patient's life depends on it. And thank you very much for your attention.
Thank you.